Good morning.
Good morning.
I'm Margaret Foster Riley, the Dorothy Danforth Compton Professor here, or Dorothy Danforth Compton Professor here at the Miller Center, and one of the co-directors with Guy and McKee of the Miller Center's Health Care Policy Project. The Healthcare Policy Project focuses on domestic health policy and global health security. Today's topic focuses on both. It's my pleasure to welcome you here today on behalf of the Miller Center and the Center for Strategic and International Studies as we explore a topic that could not be more timely. How can we build the CDC that the country needs? We'll be discussing a report released on January 12th by the CSIS Commission Working Group on the CDC. I had the honor of serving on that working group. We're joined today by two of the authors of the report, Dr. Steve Morrison and Tom Inglesby. We'll also benefit from the expertise of Dr. Ann Zink, who will help us understand the crucial relationship between state and local authorities and the CDC. I'm excited to tell you that this morning, the Washington Post editorial board endorsed largely the entire report, and it's extremely exciting. At the end of our panel discussion, we'll take questions from both the online participants and also from the in-person audience. If you're online, there is a question function at the bottom of your screen. Please push on that and it will take you to a place you can post your question. If you're here in the room, you'll see that there are cards that have been distributed. Please pass those back to the back of the room. Our panel this morning includes Dr. Ann Zink, who is the Chief Medical Officer for the state of Alaska and the current president of ASTHO, the Association of State and Territorial Health Officials. As a practicing emergency physician, she has devoted her entire career to improving patient care and reducing costs. She was in her role as Chief Medical Officer for the entire pandemic. Despite a daunting portfolio with Alaska's DHHS, she continues to take shifts in emergency medicine. Dr. Stephen Morrison is a Senior Vice President at the Center for Strategic and International Studies and founder and director of the CSIS Global Health Policy Center. Since 2018, the CSIS Commission on Strengthening Americans' Health Security has addressed the evolving challenges of COVID-19 and the tests of US leadership both here and abroad. He is also currently the James R. Schlesinger Distinguished Professor here at the Miller Center. Dr. Tom Inglesby is the director of the Johns Hopkins Center for Health Security at the Bloomberg School of Public Health and has a joint appointment in the Johns Hopkins School of Medicine. He has served as senior policy advisor for the White House in 2021-2022, and previous to that, worked on COVID-19 issues as a senior advisor in the Office of the Secretary of HHS and on Maryland's Governor's COVID Response Advisory Committee. He has also led the National Science Advisory Board on Biosecurities and a document just released with the proposed biosecurity oversight framework for the future of health science has just posted. We're going to have to do a program on that too. Let's move. I'm going to give you a little background and then we'll start our panel discussion. The CDC was born out of World War II. Its antecedents were created out of the recognition that more wartime losses were the result of contagious disease than they were of military action. On July 1st, 1946, the Communicable Disease Center opened its doors in downtown Atlanta. It was seated in Atlanta because its main mission was the eradication, or at least the prevention, of malaria. And the malaria hot zone was the American South. The following year, it was given for a token amount, 15 acres on the Emory campus that became the headquarters it holds today. Within a few years, CDC became the primary US agency for epidemiology and disease surveillance. The CDC almost didn't get through the Eisenhower administration. At a time when NIH's budget was ballooning, CDC's was cut by a third. It has seen peril before. But success with polio and later pandemic flu sealed the success of the agency. Over the next decades, its mission and capabilities expanded, and it became known as a premier scientific agency with a stellar international reputation. The year prior to the COVID pandemic, the United States was viewed as the country most prepared for a possible pandemic. And much of that was because of the CDC's capabilities. But as COVID became a pandemic, CDC struggled. There was inconsistent advice about masking, an embarrassing and disastrous effort to produce the diagnostic tests. States were frustrated by advice that did not come quickly enough or clearly enough, and there were continued and constant communication gaffes. Public support for the agency dropped precipitously. There were also a lot of successes, and that can be lost in the criticism. And I think it's important to recognize that CDC staff worked tirelessly as the pandemic kept up its fury. Nonetheless, as we continue to live with COVID today, and as we prepare for the possibility of another pandemic, it seems clear that the CDC needs a reset. So we're joined here with three experts who can help us unpack what that reset should look like. Before we look at discrete questions, what I'd love is for Steve, you and Tom to set the scene. How did this report come about? How did the working group come about?
Great, thank you. Thank you so much. It's really a delight to be here. A special thanks to Professor Riley, a special thanks to Christina Gottardi-Lopez-Chow, who really worked hard to pull this all together, and a special thanks to the production team here at the Miller Center, and to my colleagues, Tom Inglesby, Ann Zink, Mimi, who all served and very actively engaged in this effort. I'm going to say just a few quick words about how we did our work and what some of our operating assumptions were. We formed this group at the end of August. August 30th was the first session. We published the report January 12th. In real terms, that's kind of rocket speed, and it was very deliberate. We wanted to move fast. We wanted to get an analytic piece out before the new Congress settled in. We could see that storm clouds were forming around CDC, and our expectation was things would get worse. I'll say more about that in a moment. We had 4 meetings. We started our first meeting with CDC Director Rochelle Walensky there to brief us, along with some of her senior staff. Throughout the process of the 4 meetings, worked in very close alignment with CDC in order to listen and hear their perspectives on this. And we're very grateful to them because they were very generous and very candid with us in talking about topics that weren't always comfortable topics, but they were honest and candid and open in bringing forward that. And that was very important, particularly as you look at this report. We wanted the recommendations to be very concrete and specific and actionable. And neither Tom nor I came to this task fully conversant with every last complicated dimension of how CDC operates and what it needs. We did very extensive private outreach. Tom and I did a series of private conversations with senior folks from the Trump administration, from other administrations, currently serving and past governors who proved to be very, very important. Some of those are listed in the acknowledgments, but those became very important in filling in the picture. We started with the premise we had to be bipartisan. We had to show that this was something that transcended our divisions and that we could rally authorities, experts, opinion leaders from different sectors. We formed a 36-person working group. We deliberately included in that folks from industry, folks who had served previously as CDC directors, FDA director, but also people who came from different walks, from the law faculty here, from industry, from philanthropies, people who had a stake in this outcome and a perspective on it. We wanted it, as I said, bipartisan throughout, and we wanted to come up with recommendations that could be attractive on a common sense basis to people across political lines. Now, a couple of our premises. One is that is the starting point, which is that in the United States, Americans need a public agency that will be effective, high-performing, reliable in protecting Americans. And that is an essential element of national security, and it's part of the compact that our government has with its people, and we'll say more about that. But that was a starting point. This is a matter of national security. We have to have that capability. Second is there is a serious problem. Almost everyone that was joining this effort started from a position of great sympathy and concern for CDC. They didn't come from a position of a cynical rejection of it, but rather a position of concern that in performance, there had been the stumbles that Professor Riley mentions. There had been a precipitous decline in public trust and confidence that was not just confined to one sector of our society. It was variable, but it cut across multiple sectors of our society and multiple places of governing power, whether you're talking about governors who freely told us in private their discontent, or it was party leadership, Democrat and Republican. It was folks in the senior ranks of this administration and previous administrations. This was not a strictly partisan issue. It was one in which there had been a decline of public trust and confidence that was pretty widespread and cut across different sectors. Storm clouds were forming. Our view was it was not going to get any easier, and certainly that's the case now as investigative committees are being stood up in the House of Representatives, including one dedicated to the COVID response, which will call to account CDC, and we hope in a constructive fashion versus one that is more performative or damaging. We focus, this is meant to be not encyclopedic, but to focus on core areas. Data figures very prominently. Budgets and budget flexibility and surge capacity. Clarifying the mission. Addressing internal cultural issues of scientific excellence, academic perspective, operational excellence. We know that certain core competencies are weak or missing, and that includes a sort of operational surge capacity and ability to deliver to key partners at the state, local, territorial, and tribal level, but also competencies in the halls of power, an ability to bring across CDC's positions and argue them forcefully, an ability to communicate effectively with the American people in a way that's intelligible and trusted, and an ability to communicate and engage in ongoing and rigorous outreach and engagement with Congress. All of those core competencies were things that we talked about at great length. A few final closing things. This is a politically charged topic. These are divisive issues. These issues are very complicated administratively, operationally, financially. There are no quick and easy answers or fixes to these problems, but we had to both be very sensitive and navigate the politically charged context, but also demonstrate that we really had done our homework in trying to grasp the complexities administratively and operationally around these issues. CDC, we are arguing, has to grab the moment. The CDC leadership is leaning in that direction. We credit Dr. Walensky for her courage in moving an agenda forward called Moving Forward. But the point is, need to jump forward, grab this moment, and not be too risk averse or engage in half measures. It really needs to be deliberate and forceful. We also make the case that most of the power to enact reforms lies outside of CDC. The power rests at the White House, at the level of the Secretary of HHS, and within Senate and House leadership of both parties. And until we see a consensus form bringing all of those together around the reset agenda, we won't see progress. And there's an urgency to this. There's an urgency similar to what was experienced when the Challenger crashed in '86 and thrust NASA into crisis, which required multiple years of concerted effort that cut across party lines and agencies. It's similar to FEMA stumbling during the Katrina debacle in 2005. We're deliberately drawing a comparison to those earlier moments in order to say this is the type of moment that CDC finds itself in. I'll just close there. Thank you.
Tom, anything to add there?
Sure. Thanks. First of all, thanks so much for having us and for this forum today. It's a great place to talk about these important findings and ideas on how CDC can get stronger. I completely agree with Steve on so many things that he just talked about, but just in the original premise that the country deeply needs a highly performing, scientifically proficient and excellent CDC. And it's in all of our interest to do whatever we can to help move it in that direction. I was fortunate to be able to work alongside CDC leaders and workers and scientists during part of this administration, and was constantly impressed by how hard people were working and how they were all after the right things, motivated to do the best they could for the country. And it has been it's been a set of very serious challenges for CDC in the last few years. I think one insight is that during these moments of crisis, there is a window that opens for change. And we see that after big national events, reckonings around something that went profoundly wrong, and the window opens, and it's open for a time, and then it closes, and policymakers and the whole process moves on. And I think all of us who have been involved in this are very hopeful that this is a moment where the window is open for positive change, and this report is intended to be in service of that change. I am kind of a lifelong fan of and supporter of CDC, and think extremely highly of Director Walensky and many of the top people who work there. But this has been a really tough time, and I think everyone in and out of CDC acknowledges that it's been a tough time. And so our report really was written in the spirit of what can we do to strengthen CDC. This is, as Steve said, this is the opposite of a gotcha kind of cynical account. This is more looking from the outside, what can be done to fix a shortcoming or to create a new authority that CDC lacks and so couldn't perform in a certain way? Or what can we do to help CDC better connect with state and local leaders like Ann and to help them in their mission? What are the things that we can do? Because as Steve said, so much of the power to make change here for CDC lies outside of CDC's direct control. Congress has to be involved in strengthening CDC, the White House, HHS, external partners, their outside constituents arguing for more support of CDC. So much of this work is kind of rallying around the institution, thinking about what can be done to make it stronger, and then that in concert with the things that are already beginning to be underway internally to change things and make things better. So very excited to talk about this report with you today and get into some of the details, but thank you again for having us, and really grateful to be talking about this today.
Thanks, Tom. I want to start with a more basic question, Steve, and that is the report states that a high-functioning CDC is necessary for national security. How is it that a public health agency is necessary for national security?
I think the most obvious answer to that question is that because we were not adequately prepared in this instance of this pandemic, we're now in the fourth year of this pandemic. We're now in the fourth year of this pandemic. We've lost 1.2 million Americans. We have long COVID affecting somewhere in the range of 7 to 23 million people, and we're still losing 300 to 400 people a day. Our economy was grossly dislocated. People suffered in terms of the disruption of society, in terms of schooling of children, in terms of employment, and it cut across and aggravated and exposed many of the inequities that cut through our society along racial, economic grounds, rural versus urban. It was disruptive and destabilizing and with enormous human loss. And I think that itself, and we were not alone, this was a global phenomenon which required both national and global solutions for security. It was destabilizing at a global level. And so that's the first answer. The second answer is, look at what's happened in the generation of new national security thinking by the United States. We have a new national security strategy. We have a new national defense strategy. We have a new national biodefense strategy and implementation plan. And shortly, the Department of Defense will be issuing its biodefense posture review. Secretary Austin will be releasing that in the March-April timeframe. Across all of those major doctrines, that top-line thinking around what defines U.S. national interest and national security. Obviously, our near-peer competition with China and Russia figures very predominantly. But if you go and read any of those, you will see that biological threats, naturally occurring, human-engineered threats, biological threats have dramatically stepped up and been given an elevated visibility and salience as a matter of U.S. national interest. So it is enshrined now, and it's embraced on a bipartisan basis. You do not have folks challenging the merits and value of that logic, and that is now a dramatic change in U.S. national strategy. Now, it begs all sorts of questions. Are we putting in place the policies, the funding, the programs commensurate with that change? It is also another signal of this is the fact that the White House has been enshrined and continues to be strengthened as a central agency for overseeing the coordination and the accountability of the multiple parts of the federal government that are responsible. If you look at the omnibus spending bill that just passed for FY23, a lot of language included in there from legislation proposed on a bipartisan basis in Congress that says the White House needs to build new and deeper and permanent capacities around managing biological threats. That's another piece of evidence of the fact that there has been a dramatic and profound shift in U.S. thinking about just how much these biological threats pose a threat to the lives and well-being of American citizens, and that the government at multiple levels has a responsibility for protecting Americans because of that national security stake. And that's true at home, but it's also a global function, because we know you cannot protect Americans and be indifferent to what's happening outside our borders.
Thanks. Tom, I talked about a reset, and in the report and at the beginning of today, Steve talked about that this is a moment that FEMA had after Katrina, similarly NASA after the Challenger. What's a reset in this context?
I think a reset is a series of visible, important changes that are widely recognized as strengthening CDC's capacities to respond. So this isn't something that it's kind of tinkering on the margins of a particular program. This is a realignment of core capabilities at CDC. This is Congress, in our view, creating more budget flexibility for them to be able to operate in crisis and be flexible in crisis. This is CDC changing its hiring practices so it can retain talent, it can get new talent quickly. That's not a process it can follow right now. It takes quite a long time to get new talent into CDC. So it's a series of big changes that help them with their people, with their operations, with their budgets, and with both their domestic and international presence. I think we'll get back to international, but I think at the end of this series of changes, people on both sides of the aisle, in and out of CDC, will step back and say, wow, that was a big moment of transformation for the good. So kind of the reset would encompass all of that work together.
Thanks. And the states and local governments rely on CDC, and CDC relies on the states and local governments and tribal governments. What were some of the strains and gaps that were revealed by the pandemic, and how can we fix them in less than an hour?
Less than an hour. Awesome. Well, thanks, Mimi, so much for having me here, and it's always wonderful to learn. It's been great to be a part of this conversation with CSIS. We are a United States of America, and need to just start there. We are a federation of states that are brought together under this great union, but really the legal authority, as well as much of the implementation, is within states. And I think that we as a nation have had a misperception that authority lies within the CDC or within the federal government, when much of it lies within the states. And so the CDC has done a tremendous job trying to get data to be able to say, this is how many cases we have, or this is what the risk looks like. But the reality is that you have to get that from state, local, and tribal and territorial jurisdictions. And sometimes our local laws prohibit us from sharing data. Oftentimes, we do not have the tools and resources to share the data, even if we wanted to share the data. And then we are also that final mile of how do we get out vaccine? What does this look like in healthcare capacity? How are we educating the public? We live in a big and beautiful and diverse country. And what is happening in New York looks really different than what's happening in Utqiagvik, Alaska. And so the recommendations and the resources are incredibly different. And that really also hits to equity. If you are not speaking either literally the same language and or culturally making that relevant, I have 32 communities with inadequate running water and sewer. And so wash your hands with soap and water doesn't resonate in the same way as may say if you've got clean access to water in your community. Isolating from others in your community when you don't have housing to do so doesn't look the same. And so I think CDC was incredibly challenged to have one message that resonated across an entire country. And I think we need to recognize that will always be a limitation. And I think we need to embrace that limitation. We need to embrace that diversity of our country, and we need to embrace the diversity of our states. And instead of having that expectation that one voice or one specific message is going to resonate to everyone, recognize CDC's incredible scientific expertise and create better two-way dialogue and conversation about what does the data show us and where are we at in this particular health challenge and how do we partner together. And I can go through a whole bunch of examples of where everything from data and understanding to recommendations become very nuanced, and where that local, state, and federal government partnership is incredibly important. I think if you were to ask most state health officials what was the number one thing CDC could do better or we could do, it's two-way bi-directional conversation, because what this means in my state is very different than what this means in New York. And being able to have that conversation, I really appreciate their engagement with this process, their engagement, communication, and trying to improve that so that we're more nimble and we're able to respond not just more quickly, but more relevantly. Everyone wants to see the me within the we of the data. They want to see, what does this mean to me? What do I need to know about my community or my actions? And the more that we're able to granularize that, the more that we're able to localize that. Just like all politics are local, all public health is local. And I think we need to keep that at the forefront of these conversations, because one standardized world or national message is going to be challenging. Yet 3 different national messaging is also incredibly challenging. And so if we get 3 different messages from large federal agencies, that becomes really hard as well. So having one way to speak as a national entity, and then having two-way communication with state and local so that we can help to influence that conversation to say, this isn't going to work here, or help me understand what this means for my local population so that I can then message it locally, is incredibly important.
And you mentioned data, so let's drill down on that for a little bit. The omnibus bill that just passed in December did not mandate that the states share data with the CDC. But that data sharing, as you mentioned, is crucial part of the CDC's role with the states. How do we incentivize and improve that data sharing?
That's a great question. And I oftentimes, in part of conversations, when people say, well, you should have to share it with the CDC. As I mentioned, many of our state authorities prohibit us from doing that. I also think that personal health information is a highly valued thing, and we need to be really careful on what that looks like. So not all data is the same. I think that there's a real under-recognition of the challenges of collecting data, of understanding that data, and sharing the data to CDC. So if we want to incentivize and we want to improve data sharing, which I think is core to being able to have any fundamental response, we need to invest in the data and data systems that allow us to be able to get data, understand it, and be able to move it on. As you mentioned earlier, I'm a practicing emergency physician. As clinicians, we love to complain about EMRs and how hard our electronic medical records are. Let me tell you, they've got nothing on state government. State government is like duct tape and string. I mean, we literally took National Guard personnel and put them in our state lab to enter one positive COVID test into 3 different data systems because that was where we were backlogged. Most of my epidemiologists did not function as epidemiologists during the COVID pandemic. They functioned as data entry people between siloed IT systems that did not talk to each other. And so we couldn't ask incredibly basic questions. That was just how many positive tests we have or how many cases we have. Those were really simple questions. But if you want to add even one layer of how many positive tests we have in someone who's vaccinated or unvaccinated, those are completely separate data systems that don't cross to each other and don't talk to each other. So we're incredibly limited in our ability to understand and to be able to be nimble and to be able to work across these data systems. And that's just because we don't have, and it's not that we don't have the technology, right? I can go to another country today and I can take my ATM card and put it in, and I can securely get money out, and it talks to my bank and it talks to that bank, and it's able to do all sorts of conversions on currency. And I would suggest that we all consider money a fairly secure thing as well, that we don't want regularly shown. But we have incentivized the banking industry to have cross collaboration because it makes our lives easier. We don't do that with data, right? People come into the emergency department all the time and they say, I take 2 white pills. And I'm like, awesome. I have no idea what that means. And I can't figure it out to help you because I don't have any access to the data systems. And they look at me at the computer and say, well, shouldn't you figure it out in there? And I'm like, this one doesn't even talk to the one that's in the office I'm working in. And it definitely doesn't talk to the public health one, where I have a piece of paper on the whiteboard behind me with the public health number that I would call and fax you if this is an issue. So, I mean, that's just in a very individual case in that system. But we do it with money. We do it with all sorts of other things. And so this is not a technology challenge. This is a will, a policy, and a financial challenge. And I really hope that we're able to take this moment and truly invest in the public health infrastructures and force interoperability, because I think it's going to make it more secure. I think we're going to get data in patients' hands, and that's where it belongs, is with people. And I think we'll be able to better understand de-identified and de-aggregate data that helps us to understand the challenges that we have, getting back to your earlier question about public security and about national security. It's hard to go to work when you're feeling miserable. 71% of our young military are unable to serve because of physical health conditions. Like, this is fundamental to our national security, to our economies, and to how we're moving forward. And so we've got to figure this out if we're going to be able to figure anything else out.
So let's stay on digital information for a moment here and follow up on the other side, on CDC's capabilities. Tom, right now, CDC is forced in real time to have individual data use agreements. What needs to change at the CDC level?
Well, first of all, it's just worth saying what the implications of that are. Like at a very high level, CDC was criticized over the course of the pandemic for not having the most recent data, the most thorough data, I mean, for reasons that Ann is describing, it's certainly understandable how this is, where we are, how we got to where we are now. But from the very beginning of the pandemic, CDC has been saying that if the administration and Congress and the public and the media have an expectation for CDC to be the synthesizer and communicator about the national picture, it has to be able to assemble the data from all of the states. That's the job of CDC as the national public health agency that serves the White House, the Congress, and the public. So CDC leadership has been saying since the beginning of the pandemic, we need more authority to gather data. I think they recognize that the data systems that we have in the country are not where they need to be, and they're aware of that too, because of leaders like Ann, who communicate very clearly where the state of affairs out in state and local health systems. So there is a data modernization initiative going on that CDC is supporting. It's not enough, but it's a move in the right direction. And then in addition to that, what CDC has sought from Congress and what this report strongly supports is for CDC to have more authority around data gathering, setting standards, trying to improve the efficiency of data movement between states and the federal government. I think many states right now already do everything they can to provide CDC their data. So it's not as if states aren't trying, but they do it in different ways. Some of them at moments have been a little less interested in sharing data immediately. There are different approaches to this. So if we're going to continue to have CDC have an expectation that CDC is going to provide us, the country, the data that we need in the middle of a pandemic, we have to do better to integrate what the states are bringing in and what CDC is able to gather in real time. So it's a longstanding problem. Congress can help. CDC can't fix this problem on its own.
Steve, since its foundation, the CDC has been based in Atlanta. The report identifies that as a problem. How does the CDC's location undermine its authority, and what can we do to fix that?
Thank you. We're not arguing, let me just be clear, we're not arguing for the CDC headquarters to be uprooted and relocated to Washington, D.C. We raised that possibility, but that's not where we're landing. And I want to be clear there, because some discussion has suggested that may be the case, and it's not the case. What we're saying is that CDC lacks competency in a couple of key areas. It's not equipped to compete in the halls of power effectively with senior level personalities who have gravitas, who have expertise, who understand the interagency process, and are there in Washington on a continuous basis, not an ad hoc basis. And so we're arguing the presence within Washington needs to be substantially upgraded in order to do three things, really. One is be able to operate competitively and be respected and be brought to the table in the halls of power in the interagency debates, and be able to represent the interests of CDC in debates that bring the White House and the other federal agencies to the table. And we have been able to explore this in countless conversations about the ways in which that is not happening. And so that needs to be fixed. A second piece is the engagement with Congress, which needs to be very much upgraded into continuous senior level engagement with those on the key subcommittees, those members of Congress that are on the key subcommittees in both chambers, leadership and the like. When you have your leadership coming to Washington, I mean, continuously, you just simply don't achieve that. You don't have, and when you compare it to other agencies, you talk to other parts of our government where the agency head has had lunch or coffee with every member of key subcommittees in every cycle on both parties. it's a qualitative gap. And that needs to be fixed. The other is the communications piece. That doesn't necessarily mean you have to be centered within Washington. But in this day of misinformation, disinformation, pervasive conspiracy thinking, and the like, there needs to be a step up in the capacity to reach the American people effectively with the voice, the independent and autonomous voice of CDC as an effort at rebuilding confidence and trust. And some of that needs to be Washington-centered as well. So I think we make the case that this is something that can and should be done, and it's not something that is meant to suggest to the people of Georgia that we want to see that key, that jewel of Atlanta moved to the suburbs of Washington, D.C. Thank you.
Tom, a sort of related question. CDC shares overlapping authority with an alphabet soup of agencies. FEMA, for one, the White House-based American Rescue Plan, ARPA, and DoD. What needs to be done to clarify its mission?
So for the most part, I think within the agencies of government, there is a pretty clear understanding in this administration what people are responsible for. I mean, there always is, it's always useful to continue to clarify leadership intent from White House and HHS about things that might be in the seams. But I think at a high level, the missions sound fairly similar, but they are pretty distinct. So for example, CDC clearly is responsible for interaction with state health agencies on outbreak control, on providing advice, on access to experts in particular diseases, on healthcare infection control, how to prevent things from happening in hospitals. And a sister agency in Washington called ASPR, which is also a preparedness-oriented agency, has responsibility for contracting with vaccine and diagnostics and therapeutics companies, for distribution of medical countermeasures in a crisis, for sending out medical teams, operational teams to help out in with healthcare system crises. It also has some interaction with the regional disaster response work that FEMA does. So I think within ASPR, within CDC, within FEMA, there is a pretty clear understanding of what their mission is, but it has become confused by, in the outside world, it's less clear, maybe to state and local health agencies. I think Anne could comment on this. There probably is some confusion about what the best way into the government is at times. And I think in Congress, there is some confusion. And in the press, there's some confusion about who's doing what. I think, a way to clarify that is what Steve talked about before, is more high-level engagement between the White House and Congress and CDC, kind of clarifying and setting the table. This is where our work is focused, and this is where other agencies are doing their work. That's not only true domestically, but also internationally. USAID does important international work. CDC does very important international work. They have different missions, and sometimes, one overshadows the other. USAID's got a much larger budget and a much, much bigger presence in Washington. So sometimes CDC's work is kind of smaller and is dwarfed by USAID. So these are things that I think can be clarified. And when I think clarifying them would give more, would propel the things that are in the mission set in a stronger way, and would be helpful, very helpful in Washington.
Anne, do you want to follow up, or I can move right on?
Yeah, I mean, I could go on for an hour about that topic as well. I think it is incredibly challenging as a state. You're like, wait, HRSA sent out testing here, but ASPR is now providing some more, but I thought CDC was doing testing. I mean, testing would be one small example. It becomes incredibly complex. And I think just as funding needs to be braided at a federal level, it's not, I think, I sometimes bristle at the comment of like, we need to reevaluate CDC's mission. We all had and continue to have a mission regarding the health and well-being of the people that we serve. Yet we all play different roles in that, and whose role was what and who took on first continued to change. I mean, we would oftentimes have conflicting national meetings at the same time with different federal agencies about the same topic. The amount of kind of cross-wiring information that states and local entities get becomes incredibly challenging to be able to action it. And there's a lot of noise that then gets built up in the system and lack of efficient effort because you're not sure who's on first for whatever object or what needs to move next. Hospital data reporting, how to get, additional PPE, what tests to be able to use. Again, a lot of my perspective always comes back to my emergency background, but if you have a trauma, you have a very set guidelines on who runs that mission. And I think ASPR has a very kind of set, clear mission statement in that I love our infectious disease colleagues, but they're not probably the best people to run a trauma at that moment. But having that skill set between the infectious disease space and that trauma space is going to be able to lead it best. So how do we take the knowledge and skills and expertise in CDC and the program operation within something like ASPR and blend them together, particularly in fast-moving real-time information, and then hand off authority as things slow down or pick up depending on the needs? I think that coordination at the federal level is paramount and needs to happen to be able to have an efficient response moving forward.
So I have a question for all three of you, one that's probably rampant in the audience as well. We live in an era of misinformation and disinformation. CDC's efforts of communicating information during the pandemic crisis have been rightly criticized. One issue is that the agency often waited too long to offer information. It seems to be unwilling to communicate effectively when there's still significant scientific disagreement or uncertainty. But that communication is crucial, both for the states and the localities and for the public at large. How do we cultivate the CDC's independent voice and improve its communication capacity for the future? Steve, you want to give us a start, and then we'll move to Ann and Tom.
Thank you. This is a challenge that many different agencies of government are confronting right now and finding it very uncomfortable. The Department of Defense is getting beaten up every day around its biological programs in Ukraine and its biological programs in Georgia. And when you do survey work in Europe of attitudes towards those biological programs, those disinformation campaigns are cutting away at the credibility and standing of the United States in those areas, just to give you an instance. And trying to figure out what's the strategy for reaching those publics with quality information that's trusted and that cuts through the haze. It's not a simple issue at all. And CDC needs to, I think, acknowledge that this is a long-term challenge that requires new competencies. The communities that have come forward, the disciplines that have come forward to look at disinformation, misinformation, conspiracy thinking are outside, many of them are outside of public health. These are folks that are looking at algorithms. These are folks that are looking at psychology. These are folks that are looking at anthropological issues and community engagement strategies and the like. And there's a lot of thinking going on within universities like UVA and others around this phenomenon. And that knowledge base has to be tapped and integrated into new strategies. And it's a long-term problem. I do believe that speed is important. I do believe that consultation with communities as guidance is cultivated without slowing down. There needs to be greater openness and greater transparency and accountability to publics that are concerned, so that the sort of perception of secrecy and delay has to be corrected and done away with, so that early consultation is important. Community engagement, and I think Ann can speak to this far better than I can, is also fundamental at restoring trust and confidence and getting people to listen and believe, and not simply listen and dismiss because they're hearing from wherever source completely contradictory information that is distorted and filled with falsehoods and lies. And that's the environment we're dealing with right now. And there's always been that contamination of the communications environment, but nothing like we've seen since 1998, frankly. And we've been slow institutionally in our public health agencies and other agencies. As I said, this cuts across government agencies. We've been slow to grasp the magnitude of the problem, the degree to which public support and trust in science has decayed, and in public health institutions and authority in general. And we need a much better and more competent ability to do that. And we should expect that, as we've seen already, efforts to create those competencies will themselves be subject to attack by those who see them as part of a larger conspiracy of government, which we've seen. You know, initiatives that were launched within HHS and elsewhere to start understanding and figuring out what the strategy were themselves then the topic of conspiracy thinking.
And you want to follow up on that?
You know, it's great, and I would agree with many of the things that Steve said. You know, I appreciated, Mimi, how you started off talking with some historical context. And, you know, Steve emphasized the fact this happens in other agencies, but I would also just emphasize the historical context that there's always been a degree of mistrust in what that looks like. But the fenestration of how we get information, really with everything from social media to the way our communities are now aligned as much online as they are physically with where we're at, I think provides some really new challenges. Just as Steve mentioned, I think that we really need to invest in and understand communication, just like we understand diseases. You know, there's an R naught of a tweet compared to an R naught of a HAN bulletin that our team puts out. And I'll tell you that HAN bulletin does not move around society nearly as quick as that tweet. And so how can we understand just the mechanism in which these fly and that they move? And then how can we understand who's susceptible to different information? And then how can we vaccinate people for misinformation? How can we give them the tools and resources to be able to process what they see when they get it? You know, I oftentimes said during the pandemic, when people said, if you could have one thing, what would it be? And I would be like, for people to understand denominators, you know, like just understanding some basic science behind it would really help me be able to deliver my message in a way that landed in a way that people understood. And so I think that even just basic science and education needs to be a part of how we're thinking about information, misinformation. I think just like Steve said, thinking also about the way that this is local, that this is relevant, and not saying, well, this worked well for us 50 years ago, or this worked well 10 years ago. What does this look like now? How my kids want the information delivered is really different than how I want information delivered. I've gotten much better at, you know, Snapchat and all sorts of other mechanisms to talk to them about how their day is going than I do with my parents. And so I think we need to be very much looking future forward about how the information lands, what do we do? And then the last thing I want to say is I think healthcare moved this concept of shared decision-making 20 to 40 years ago, right? It's not take two of these and call me in the morning. I'm in a white coat and I'm just going to tell you what to do. It's, you know, here's the risk benefit of what you need to concede. A striking thing that I continue to see during the pandemic is the public health is still very much in the, this is what you need to do and we're all going to be okay. And I think we need to move to that shared decision-making with the people we serve. This is the risk benefit of what you do. This is the risk benefit of this decision as we understand it now. And we're here to partner with you to be as healthy and well as possible. And so I think we need to think about those messages in a shared decision making capacity and how we can have authority without being authoritarian.
So we have a lot of questions and very limited time. So I'm going to weave some of the questions into the last question before closing. And that is, so we'll start with the way I had framed it, which is last week, Scott Gottlieb, former FDA commissioner, had an op-ed in the Washington Post that mirrored a lot of what CSIS has said about the CDC, but also argued for shrinking the agency considerably. One of our audience members said, well, if all health is local, why have a federal agency? There's a lot of also within this what the mission should be. And so a question I have for all three of you in 1 minute each is, what should that be?
Want me to start?
You start, you get 1 minute.
1 minute. This debate about what are the boundaries, what's the scope of public health agencies is something that we face here and we face in every country. The Canadian authorities were here this week, and they said we're doing exactly the same thing. We focused on pandemic preparedness and response CDC. We did not focus on the very important work that it does on chronic diseases, on the environment, on the opioid crisis, on smoking, on climate change, on workplace contamination, a whole range of things, all of which have constituencies associated with them, many of which can be politically divisive in the wrong context. But we are at a moment where we're going to need to decide, where do we delimit that? How expansive is that? And this gets to the question of accountability and transparency, and it gets to the question of forging a bipartisan consensus on a way forward for revitalizing and resetting CDC is going to require some consensus around this issue. Are there things that CDC does that it should not be doing or could do without? And that debate is just opening. And what Gottlieb has done is open that debate. The Washington Post editorial today that embraced our report makes the point that these areas remain highly valid, and we should not be sacrificing them for the sake of rebuilding the pandemic preparedness and response capacity, and I agree with that.
Tom, quick response?
Yeah, well, I have great respect for Scott Gottlieb, but on this particular issue, I don't see the connection between ending a particular CDC line of effort outside of infectious disease and how that would strengthen the infectious disease response for the country. And we spent a lot of time in the last 4 months looking at strengthening the pandemic preparedness efforts and the epidemic preparedness efforts of CDC. And we didn't hear a lot or any analysis or data that said if we shut down these multiple programs, then this core infectious disease response program will, as a result, become stronger. I think they're both important policy issues. I'm in favor of continuing the work CDC does outside of infectious disease response and preparedness, but that was outside the purview of this report. I think they do very valuable work in that realm, as well as in the infectious disease preparedness and response realm. I think really we just need to focus on, as the highest priority, what makes the work of CDC's preparedness and response to infectious disease epidemics stronger. That's what I think we should, the eye on the prize for this particular policy window that is open. And I think that's what this report really focused on.
So now we're down to 2 minutes and 30 seconds, but combine your closing, low-hanging fruit and priorities.
I would echo what was said. I would say that CDC has a real mission not to separate the bug from the person. So the whole person needs to be thought of. So I would not support just an infectious disease component. 2, CDC plays a huge role in federal coordination with local and state in providing scientific information and data that is unable to be obtained locally, such as being able to understand vaccine efficacy and safety. I will never have the data at a state level that can be able to tell me that. I need that national perspective, and I need that scientific review to be able to support me. Closing, CDC is remarkable. They're amazing people. They're great people who have served us in so many ways. And as Tom mentioned earlier, this is an opportunity in a window. And if we look historically, we've made tremendous change in this country when we learn from our mistakes. And I'm just really excited for this opportunity to learn from this and be able to pivot and create a stronger response in the future.
Tom, close.
Well, hard to say it better than what Ann just said. This is a really important time for reflection and change at CDC. I think all of us outside of CDC are the constituents that CDC is helping it's helping our mission. We are trying in turn to help shape and strengthen CDC's mission in the time ahead. I think this group of 36 people who got together in the last 4 months really spent a lot of their passion and energy in trying to develop bipartisan solutions or steps for positive change. And just excited to have been talking about this today. And we're going to keep bringing this forward to policymakers in the time ahead.
And Steve, wrap us very quickly up.
I think we know what we need to do. I think we've identified that. I think that we've been successful at demonstrating that solutions are in sight. and that people of goodwill and common sense can rally behind those. And that was our goal, and I think we've been successful. The question now is keeping the momentum and building an alignment of folks who, outside of public health, around this, getting governors rallied around this, getting state public health officers like Ann and others rallied behind this, and reaching the leadership within Congress to see the value of protecting Americans with this formula. Thank you.
And we could keep going for much longer, and you clearly could as well, but we are forced to bring this to a close. This is all our problem, and I hope you'll see it as our problem. Thank you.